might just keep moving, and we will introduce our next speaker. Dr. Andrew Burke is the Director of Infectious Diseases at the Prince Charles Hospital. He's a dual specialist in respiratory medicine and infectious disease, and his research interests include the pharmacokinetics of mycobacteria treatment, and he's the current chair of the Australasian Clinical TB Network. So again, very warm welcome to Dr. Burke.
Thanks, Holly, for the introduction, and thanks for joining us today. So look, Dan gave a great overview of bronchiectasis. There's been a lot of changes there, no doubt evolving over a long period of time, although it all seems to have come to fruition in a short space of time, if you're an outside observer. I want to talk about more of a niche area now, and this is about non-tuberculous mycobacteria, but specifically focusing on therapeutic drug monitoring. And in this forum, this series of lectures over the years, I've given a similar talk on tuberculosis TDM. And just as way background before I talk about NTM, we're actually in the process in Australia of writing a guideline for therapeutic drug monitoring in tuberculosis. And Dr. Vicky Gray from Logan Hospital in Brisbane is also the TB clinic at PA. She's the lead author on that, and a few of us are helping with that as a broader writing group from around Australia and New Zealand. And we hope to publish that tuberculosis TDM guideline probably by this time next year. So I guess some of the lessons we learned from that we can apply to NTM, but there's also some important differences that I will go through. And so I know there's a lot of pharmacists online, just seeing who is present. Some this week familiar, but it is useful just to sort of frame the discussions about whether TDM is useful, and there's some things we can consider about that generically, and do they apply to NTM? One of the issues about TDM in mycobacterial disease is actually really quite difficult, and there's a lot of challenges to that. And I'm going to share with you maybe the way some of my own experience has evolved over the period of time that we've been doing this here in Queensland. With no relevant conflicts. So just to reorientate us to mycobacterial disease. So mycobacteria are very slow growing bacteria. They're positive as Zell-Nielsen stain or ZN stain, which was developed in the late 1800s. And so they're not really gram-positive, gram-negative. They're sort of in a little bit of their own class, where they are sometimes seen on gram-positive staining. So globally, the most important is TB. So about 10 million people get TB every year, and about 1.5 million people die from it. So it's still the most lethal pathogen of any infectious disease still globally. Leprosy is less of a problem, although there's some talks happening at the moment around Australia, and leprosy is still an issue in our region. Kiribati is the highest rate of leprosy in the world, which is in the Pacific, not far away. And then Australia and other high-income countries, non-tuberculous mycobacteria tends to be the most dominant mycobacteria that we see. And certainly in Queensland, where it's been a notifiable disease under public health legislation for a number of decades now, Queensland has been able to demonstrate increasing rates of non-tuberculous mycobacteria pulmonary disease. And so in some ways, Queensland has been a little bit of a canary in the coal mine in being able to sort of record that data, whereas most jurisdictions around the world, NTM is not a notifiable disease, unlike TB. And just because I'll just use some of these terms just to remind us what they are. So the most common non-tuberculous mycobacteria that we see is Mycobacterium avium complex, or Mycobacterium avium intracellulare. The treatment for this is really the same. I'm not going to go through all the treatment at this stage. In Australia, we sort of see Mycobacterium intracellulare. In the Northern Hemisphere, it's more avium, but essentially they're the same in terms of treatment. And they're what we call a slow-growing bacteria, which means that it takes more than 14 days in this liquid media to, see if I get my pointer, sorry. In this liquid media, we call this a Mycobacterium growth indicator tube. The pure isolate will take more than 2 weeks to grow, whereas for rapid growing mycobacteria take less than 2 weeks. And the most common one that we would see is Mycobacterium abscessus complex. And the taxonomy of this can be a bit confusing. There's a number of different subspecies. The treatment is largely the same. The main point of difference is that Massiliense tends to be macrolide susceptible, and so has a more favorable treatment prognosis. So why do the drugs not work so often in NTM? So this is a patient I had who sadly died of her disease. She had Mycobacterium intracellulare, so slow-growing, most common NTM that we would see in Australia. She had this large right upper lobe cavity on the background of emphysema. So you can see she had this very large lungs or hyperinflation here, and a cavity on top of this. And so her disease progressed despite having drugs, despite having a pathogen which should be susceptible to her antibiotics. She was on azithromycin, ethambutol, rifampicin, and she also had IV amikacin. We did macrolide susceptibility. She was susceptible to azithromycin, susceptible to amikacin, and yet her disease still progresses. And so why might that be? There may be host factors at play. So she's got bad emphysema, so she's got underlying structural lung disease. She was not smoking at this stage, but that could be a risk factor for treatment failure. But she did have malnutrition, and malnutrition may play a role both in terms of host response to infection, but also sometimes in terms of malabsorption of drugs and the pharmacokinetics of the drugs. And so this is where TDM may have a role. Are we getting subtherapeutic exposures? And may TDM have a role in detecting this and helping us adjust our drug dosing? So if we just remind ourselves about pharmacokinetics, so it's really what the body is doing to the drug, and there's 4 main domains that we consider. So absorption, distribution, metabolism, and excretion. And so there can be some factors may predict some changes in this. Some may be somewhat idiosyncratic. We talk about inter-patient variability in some of these things. So somebody may look like me, be in the same racial group, same sex, and may have the very different excretion, for example, of ethambutol, very different metabolism of through their cytochrome P450, and some of these can't be easily predicted. Certainly for tuberculosis and isoniazid, there's some genotypes are strongly associated with isoniazid metabolism, so they're NAT2 genotypes. But for most of the NTM drugs, there's not really clear genotypic associations with any of these domains. If we come down to the pharmacodynamics of the NTM drugs, so this is what we talk about. We think about drug susceptibility testing, and this is really a reflection of pharmacodynamics. So what does the drug do to the pathogen? One of the issues with the NTM drugs is that there's very few breakpoints. So when we work out the susceptibility for NTM drugs, we tend to use the cation adjusted Buell-Hinton broth, so liquid media. And as an example, each row here would be a different antibiotic. Let's just say it was amikacin, azithromycin, ethambutol for argument's sake. And then across the vertical row here, we have increasing concentrations of the antibiotic. So this might be 0.012, 0.024, and it goes up to say 1 millimole, 2, 4, 8, and so on up to 32 or 64. And where you start to see a clear growth or cloudiness, that is what we call the MIC. And as you might expect, it can be a little bit arbitrary at times how to read these plates. And so it's being read with the naked eye, and there's quite a big difference between these two. There's a lot of difference between these two MIC values. And so this is really the best that we have. This is what UCAS and CLSI use for determining the MIC that we use. And when we think about MICs, they're really just telling us a minimum inhibitory concentration. But to be clinically more useful, we want to work with the term a clinical breakpoint, which is where there's been an association between a certain MIC and a clinical outcome in terms of cure or microbiological outcome, or alternatively a certain toxicity. So if you think about drugs that we're more familiar with, say the aminoglycosides and vancomycin, many of us feel quite comfortable now with prescribing these. We have Bayesian software to help us with dosing, and we also have more clear breakpoints which are associated with microbiological cure or alternatively with toxicity. Unfortunately for the mycobacterial drugs, including TB and NTM, with the exception of amikacin, which is an aminoglycoside, we don't really have clinical breakpoints, and so this makes the utility of TDM a lot more difficult. So when we bring pharmacokinetics and pharmacodynamics together, we try to come up with what's called a PK/PD target. And for most mycobacterial drugs, the area under the curve or the shaded part of the curve is what determines microbiological outcome. And then as an extension of that, if we're trying to develop more precise or precision dosing, we often talk about trying to get the AUC over MIC. And there's a lot of issues with that with NTM, and particularly when how we measure MIC is quite controversial. And I'm going to show you some examples of that towards the end of the talk. So we think about aminoglycosides. Traditionally, we've used a Cmax over MIC as the most important. For vancomycin, we tend to use area under the curve. And this is really sort of taken over from, rather than looking at the trough levels and things like that, we're trying to have more accurate ways of measuring area under the curve. The reason we can use Bayesian software for vancomycin aminoglycosides is we've got very well-established data sets, which we don't have for NTM. and TB. And so we're very much in the early phases of trying to determine the optimum way of using TDM in these infections. So in terms of broad, there's lots of antibiotics, there's hundreds of antibiotics, but we don't do TDM in most of them. So why might we use TDM? So if a drug has a narrow therapeutic range, again, vancomycin and aminoglycosides fill this category. If there's significant PK variability among individuals, and I'll show you an example of that in the next slide. If there's a correlation between plasma concentrations and clinical effects, and this correlation is often not very clear in mycobacterial treatment. And is there an established therapeutic concentration range that we can target? I'm going to talk about when we use about aiming for target ranges. Are we looking at a therapeutic concentration range where we have a clear upper and lower threshold, which we might try to aim or avoid, versus what's just like an expected range? What sort of ranges do we see in healthy volunteer studies, which tends to be what we have for mycobacterial infection? So this is a study that's in press at the moment, or about to be submitted for a study we've done at Prince Charles Hospital, giving patients with cystic fibrosis some NTM drugs just as a single dose. So these are all, I think we had about 20 patients had clarithromycin. They all had 500 milligrams. So a single dose. You can see here the time from oral dosing. And the main point to show you here is that there's a very big difference in the peaks. So all these patients had cystic fibrosis. There wasn't really a very great distribution difference in terms of BMI or age. They tend to be young adults towards the end of their treatment course for a pseudomonal exacerbation. Some patients have very high peaks, some have very low peaks. Some would have had a very great ranges in area under the curve. And so this is what we mean by PK variability. And this is not really predicted by someone's sex or gender or ethnic group or BMI. And so in this sense, you might think, well, maybe in the base of this, clarithromycin might be a candidate for TDM. It's an important drug, as is its surrogate azithromycin. However, it tends to be a fairly safe drug, and there's no clear correlation between the plasma concentrations and what we see in the alveolar lining fluid. And I'll give you an example of that in a moment. I think this is the biggest study that's been performed of the pharmacokinetics and pharmacodynamics in NTM. This was done about 13 years ago in the United States. And what they did was they chose some PD targets, and we'll talk about where they came from. And they looked at guideline-based therapy. So for Mycobacterium avium complex, we would traditionally use rifampicin, ethambutol, azithromycin instead of clary, and we use clofazimine and amikacin fairly commonly, less so the quinolones. And they found that only 57% achieved the target concentration for ethambutol, less so for clarithromycin, and even less so for rifampicin. And one thing they found, which has been documented by others, was that rifampicin, due to its P450 activity, does lower the concentration of macrolides, which is quite problematic. And rifampicin lower the concentration of clarithromycin by about 90%, whereas for the azithromycin, it lowered it by about 30%. This is one reason why in the therapeutic guidelines now in Australia, we suggest azithromycin over clarithromycin is because of the interaction between rifampicin and these different and how it differs in different macrolides. So we rather than accept that on face value, however, I'd just like to comment about these PD targets. And so this target that they've chosen, AUC-MIC ratio or free AUC, these are all taken from tuberculosis. Likewise, ethambutol. Likewise, amikacin is really a generic sort of Cmax-MIC ratio you use often for gram negatives. And so they've used target ratios which haven't been developed for non-tuberculous mycobacteria, let alone Mycobacterium avium complex. And so I think we have to be very conservative in when we're doing therapeutic drug monitoring and what sort of target are we trying to aim for. You might say, well, for rifampicin, we're going to aim for this AUC over MIC. And the issue is that there's no clear correlation outcome with MIC for rifamycins and NTM. So I said there isn't one, or one can't be discovered one day, but at the moment we don't know what they are. And so when we extrapolate from tuberculosis, I think that's going to be quite problematic. And so I think when you're using TDM and you're using different targets, we have to have some hard thinking about how we're going to interpret those, because there's going to be slippage when we're making these assumptions, and there's going to be compounding errors, which I'll discuss in a moment. So we're very fortunate in Queensland that we have our pathology Queensland has developed quite a broad range of antimicrobacterial drug assays, and this was done in the context of the format study, and part of my PhD is that we wanted to do some PK studies. And Burke, he's a senior scientist for the Department of Biochem for High Performance, the Good Chromatography Lab. His team really developed all this, and we're fortunate they've been accredited through NADA, and we had some recent additions, and mostly in the TB space, around some of the newer drugs. I think bedaquiline, I've put these in bold there. We do use them in NTM, but they're also used in NTM, which is why they've been highlighted in bold. So these drugs are really quite relatively cheap. The assays might be about $50, but they're really across 3 different multiplex assays. And so what happens is you might be measuring 4 or 5 drugs in one assay for about $50. And so probably for $150 per sample, you could probably test all of these drugs if your patient happened to be on them all. So you don't have to ask our permission to do this. They're NADA accredited, and we have samples received every day of the week from around Australia, New Zealand. And obviously interpreting them, though, is where the difficulty is. Just to the imipenem is withdrawn. So imipenem is quite an unstable drug, and although it initially passed the NADA accreditation on our quality control, it was failing its QC. So as a result, it's been withdrawn, and other labs internationally have also had troubles with imipenem as well. So one of the things we do when we do therapeutic drug monitoring is that we measure the drug in the plasma, because that's the most easy body compartment to measure. But if you think about where the infection is actually in the lung. And so really probably the body compartment we're most, or the organ we're most interested in really for drug exposure, what's most clinically relevant is what is the concentration, not so much in the plasma, or is the concentration in the lung. And this is a lung transplant patient who had Mycobacterium abscessus. He was on NTM treatment, including liposomal amikacin. And we took a blood sample during his bronchoscopy, and these were his plasma levels, but we also took a concentration reading on his BAL fluid. And you can see here that the concentrations in his BAL, alveolar lining fluid, are much higher, which is a good news story, okay? Because we want that concentration to be high in the lung, because that's where it's most important. He had inhaled liposomal amikacin the morning of the bronchoscopy. And you can see here, he has a concentration very much higher than most MICs would be for Mycobacterium abscessus. And so then this is all good news, but it raises the question about, well, if I do therapeutic drug monitoring on the plasma and I get certain levels, like this azithromycin level may seem low, but really there's many orders of magnitude greater concentration in the lung. So just to highlight that, this is the same for all, unless you're doing a bloodstream infection, all of our antibodies tend to target infections in places other than the blood. So soft tissue, the abdomen, the urinary tract, etc. This also applies to those other organ system infections as well. But it's just something to consider. What is the relevance of the plasma concentration when there may be a much, much higher level or concentration at the organ or where the infection is actually occurring. So this is one of the first patients we did TDM on about 5 years ago, as a patient from Princess Alexandra Hospital. And this is really based, you'll see here the time points we're using, 2 and 6 hours, or 3 and 6 hours. And this was based on papers out of the early 2000s talking about trying to capture the Cmax, or the peak concentration. And so to get the Cmax, you really have to try and time the maximum time. So what's the peak after oral absorption? So this is really based upon what was in the literature at the time. And this was a patient who was on leflunomide for rheumatoid arthritis and got a rare complication, which is an empyema from Non-Tuberculous Mycobacteria. And the patient actually died before these results came back. They're very sick. So we did our levels trying to think, well, let's target a Cmax. And again, like the earlier NTM studies I've shown you, these targets are really taken from tuberculosis. And even tuberculosis, these concentrations or these peak levels don't necessarily correlate well with clinical outcome. And even in, say, drug-resistant, or even, say, TB meningitis, there was a study presented last year at ECCMID conference where they tripled the dose of rifampicin, thinking that drug exposure in the meninges is quite low in TB meningitis. But even tripling the dose actually resulted in worse outcomes. So no real increasing survival in TB meningitis, and in fact, increasing rates of hepatotoxicity. So these are not what I would call therapeutic ranges. They're just targets based upon what we expect to find in patients who have tuberculosis. Okay, so hope that's not too pedantic, but I just think it's important to make that important difference. So this patient had relatively low concentrations of of peak concentration of rifampicin as best as we could tell, but we may have missed the peak here, and I'll show you some slides about why that might be the case. So this is the other study I showed you about the cystic fibrosis patients. These are patients who have now received ethambutol. So again, we can see significant inter-subject variability, different peaks here, but I want you to notice that the peaks here are very different. So some are peaking at 1 hour, some at 2 hours, some here at 3 hours, some at 4 hours. So if you look at the ethambutol here, the guidelines suggest that for ethambutol, we should do a Cmax at 2 hours. So try and do a level at 3 hours. Thinking that there may be delayed absorption of ethambutol compared to rifampicin and isoniazid. However, you can see here, most patients were more around the 2-hour mark. And so we followed the guidelines suggesting a 3-hour and a 6-hour peak. We would have missed the peak for most of our ethambutol patients. And so again, this is one of the problems with doing TDM in mycobacterial disease. And I'm going to come back to another example of what we might do differently towards the end of the talk. Because we've only got about 5 minutes to go, so I'll go through quite a little bit more quickly. So this is a patient with Mycobacterium thermoresistable, was put on linezolid, very rare NTM. I'd never heard of it until this case was shared with us. Was in ICU for quite a prolonged period, only a young man, and he was put on linezolid for several months. In MDR-TB now we use linezolid quite commonly, and so we're getting a bit more confidence in what the toxicity profiles are. And we tend to aim for an AUC-MIC target of 100. And because linezolid has a fairly low breakpoint in TB, which I'll show you, we've gone from reducing the dose from 600 milligrams twice a day, which is what we use to say MRSA or VRE infections, down to a lower dose of maybe half that to 600 milligrams daily or even lower doses. And we know that there is a toxicity can be predicted if levels are over 4 or over 2. And so we tend to aim for lower levels now. And the trough level can predict the AUC quite well in linezolid, which doesn't occur for other mycobacterial drugs. So if we look at this, the linezolid, the MIC distribution that we see for Mycobacterium abscessus, which is where we sometimes use linezolid NTM, most of the sort of MIC 50, if you like, is around between 8 and 16, much higher than we see for TB. For TB, the critical concentration is around 1, and yet for TB we use 600 milligrams a day, but for Mycobacterium abscessus, we're not going to be able to get that same AUC-MIC target with a lower dose. However, toxicity often limits the high dose that we might need based upon this. So we do linezolid TDM in NTM infection. It's probably where the most evidence is, but it's not so much to maximize our AUC-MIC. It's more to try and avoid toxicity. So there's a trade-off here between avoiding toxicity and maximizing exposure. I'm just going to talk now about MIC, how we manage that in NTM and how we devise that. And I'm just going to talk briefly about the format study, which some of you may have heard of. It's a RCT that are running out of Australia for Mycobacterium abscessus infection. And one of the antibiotics we're planning on trialing towards the end of this year is a drug many of you won't have heard of called sulbactam durlobactam. So it's a dual beta-lactam, beta-lactamase inhibitor combination. And in NTM now, there's quite a lot of interest in beta-lactam combinations. And I think hopefully we'll start to see some clinical trials emerging. And certainly we've got one planned in the format study where patients are going to get sulbactam durlobactam. The durlobactam has a beta-lactamase inhibitor. And what we've seen in these studies is that if you look at, say, drugs like cefuroxime, which is a CEF, and amoxicillin, they tend to have very high MICs. But when we add in durlobactam, the MIC gets very, very low. And this is because it's overcoming the beta-lactamase inhibitor that Mycobacterium abscessus produces. So we're getting some very low MICs, which suggests that by pairing this with other beta-lactams, it may be a favorable clinical outcome. I don't want to talk about too much about this concept of beta-lactams for the time being, but what I want to do is just look at the two different culture media that we have tried. So the UCAS and CLSI, they recommend the cation-adjusted Yule-Hinton broth. But if we use 7H9, which is an alternative culture media, we get much lower MICs, okay? And so these are just 3 different clinical strains, and we've compared to another group who've also found the same thing. And why this is relevant is when you're doing so-called precision dosing, often if you have an MIC, you will use that as your denominator. But if you're targeting an AUC over MIC, and your MIC is less than 0.06 using one culture media compared to 8 for the CLSI recommended culture media, you're going to get a vastly different PK/PD target. Okay, it's going to be much easier to reach your PK/PD target if you're using an MIC developed with 7H9 versus ChemHB. This being the recommended one at the moment. Lots of the papers that you will see from Mycobacterium abscessus use 7H9, and it's something that if you don't pay attention to the methods, many clinicians wouldn't necessarily care about this. But I think it's going to make a big difference in terms of what PK/PD targets we're aiming for. And I'm grateful for Kirby Faye Patterson, who's one of our medical students who's doing a project on this, and she was allowed me to share her slides, and this has been submitted for publication. And Kirby was a mycobacterial scientist before she started medicine. These are just different isolates, 4 different isolates. Again, the purple dot here is just showing the MIC for the same data in a different way with the CLSI recommended culture media. And this is when we do paired susceptibility testing for the same isolates, but with different culture media. You can see how the MIC is much lower. So it's just, I think we need to be mindful of this when we're deciding which MIC we use, particularly if we're going to start talking about PK/PD targets. I think we're not necessarily comparing apples with apples when we're comparing studies and in this in vitro space. So just finally, before I open to questions, area under the curve, I think, is the way we need to go rather than aiming for Cmax targets. In our TB guideline that we're developing, we're going to show different ways of measuring the area under the curve. You can Google it, and there's Excel, you can do it. GraphPad that many of you use can develop an area under the curve. They tend to require 4 time points though, okay? PK Solver, again, tends to require 4 time points. This is something these talks are being recorded, so you can always look these things up yourself. So there are tools available to develop an area under the curve. And one thing I think we need to move away from, and this will be emphasized in our TB guideline, is this idea of just doing a 2-hour post-oral concentration and thinking you've somehow magically captured the peak level. We really need to be going towards area under the curve. And unfortunately, that's going to require at least 3 and often 4 time points after taking oral dosing. This is a patient who was doing very poorly with fibrocavitary MAC. You can see she's got very severe destructive lung disease. She'd been on treatment for a year or 2. We did a thiambutal level, thinking she might be malabsorbing. Her weight is 28 kilos. And she had what we might say are low levels. Again, what do we mean by low levels? These reference ranges, as I said, were developed for tuberculosis. And again, even in TB, they don't necessarily correlate with clinical outcome. So we really felt that we need to develop an area under the curve for her. So I use the Excel spreadsheet and the Excel add-in PK solver. That's quite easy to do. You just have an Excel spreadsheet. You can Google it. You can make this an add-in, and then you just cut and paste and drag it into here. And you hit enter, and it gives this nice output. Okay, you can print this out and put in your chart if you wish to. And it gives you an area under the curve, which in this case was 15, beg your pardon. So that was lower than the expected range that we might see in TB patients. And based on this, we did increase her thiambutal, but we also did other things. We added minocycline, and we gave her nasogastric feeds for malnutrition for 6 weeks. And she did turn around. It's surprisingly done quite well. There's other limited sampling strategies using only 3 time points. And I just refer to this, that these things seem quite complicated once you've done it once or twice. And it's not that hard. Certainly, of the clinicians here, I'd encourage you to get a pharmacist who's interested in NTM, and of which we're very lucky. Our pharmacists tend to be very interested in mycobacterial disease because they're complicated, and it's very interesting from a pharmacology point of view. So I think the clinicians really need to have a very good pharmacist who can show an interest in this and help with this if you are going to do it. So just summary, if you came here hoping for some easy answer, I'm sorry I haven't been able to give it to you today. Doing TDM and NTM is quite difficult. I think we need to be a little bit conservative in the patients we choose, but I think it does have a role. Unfortunately, I think we're moving away from a single time point to 2 hours, and we need to be doing multiple time points if we are going to do it. And there's no clear targets for most of our drugs. So I think we should always consider the optimal dose, regardless of whether you're doing TDM or not. If the patient's not getting better, we have to say, look, do I have the optimal dosing? Are they taking it? What's the timing of taking their food? Are they doing this correctly? Do we make some empirical dose adjustments? For drugs which are renally clear, do people have low GFR? Then we know that some important drugs do need dose adjustment. And certainly linezolid is not in the product information, but I would recommend adjusting the doses. And TDM may have a role in some patients with linezolid and amikacin, but in specific situations, then I think TDM will have a role, but doesn't require some forethought. So I've sort of got a few minutes over there, Holly, but I'll stop sharing and happy to take any questions.